Hello, everybody, and welcome. We're so glad that you could join us today on Faith Day of the International Stigma Conference, the 11th Annual International Stigma Conference. Today, or this afternoon's session, is hosted by the U.S. HIV and AIDS Faith Coalition, and we are happy to bring to you the Faith Day sessions. We had two wonderful sessions earlier today and are so grateful you could join us on this one, where we'll be looking at the framework for dialogue between religious leaders and people living with HIV, a tool for dialogue and joint action to reduce and eliminate stigma. My name is Reverend Mike Schuenemeyer. I serve as the Executive Director for the United Church of Christ HIV and AIDS Network, and UCAN is how we call our network. UCAN is the lead agency for the Framework for Dialogue in the US. And I'm going to begin today's session by talking about the Framework for Dialogue, so those who are on the session today have an idea of what it is. And then I'm going to bring on board our national coordinator, Arthur Butler, who's going to talk about the communities in which we're currently engaged implementing the Framework for Dialogue and some of the folks who are involved in that implementation, and have a conversation with them about how best to engage with faith leaders and houses of worship, the religious communities in the HIV response, particularly in how we go about reducing and eliminating HIV-related stigma. Once again, welcome. We're so glad that you're with us. I'm going to get to my slide deck so that I can share that with you, and we'll be sure to make sure that the Stigma Index, or rather the Stigma Conference, has that so that you'll be able to have that after the sessions later today. So let me share my screen and get this going. Great. So as I said, this is a tool for dialogue and joint action to combat stigma and discrimination against people living with and vulnerable to HIV. The the Framework for Dialogue was formed by partners. The first partnership was around the Stigma Index itself, and that was with the UNAIDS and the global network of people living with HIV, and also with the Positive Women's Network. They were the folks who put together the Stigma Index, which has been done in more than 60 countries now throughout the world. And it was brought to the US by the US People Living with HIV Caucus. It was implemented in the Detroit metro area, in Louisiana, in Baton Rouge, and New Orleans, and also in New Jersey. The Framework for Dialogue was some of those same partners as you see here, the global network of people for and by people living with HIV, the Ecumenical Advocacy Alliance, which is an ecumenical initiative of the World Council of Churches, UNAIDS, as well as INTERRELA, which is an international network of religious leaders, lay and ordained, women and men living with or personally affected by HIV. So we begin with a basic understanding of stigma as being HIV-related stigma being the prejudice, the negative attitudes, and abuse that's directed at people living with HIV. Stigma has a variety of components. There's the internal stigma, in which people turn harmful judgments against themselves because of how they feel about themselves, and they stigmatize themselves. Anticipated stigma is related to the perceived fear and expectation of mistreatment and discrimination. And then there's external stigma, which is the result of an actual judgment or mistreatment or discrimination of others that the stigmatized person experiences. And then there's the structural stigma, which is having to do with laws and policies or regulations that have a discriminatory or stigmatizing effect. We know the consequences of stigma are wide-ranging, that they can be about a person's real or perceived HIV status. They can be shunned by family, by peers, the wider community. They can receive poor treatment when receiving services. It's an experience that creates problems in acquiring or keeping employment. It's the negative profiling and stereotyping that fosters discrimination, increases fear and insecurity, and perpetuates silence. It creates unsafe environments that can lead to violence and sometimes even death. It violates human dignity, erodes respect for human rights, and can result in psychological and spiritual harm. Stigma is a significant barrier. There's a 422-page gap report that contains 422 references to stigma, but only one reference to faith. And the 2016 to 2021 UNAIDS strategy contains 40 references to stigma and 11 references to faith. There's evidence from multi-country faith-based lens that helps us to get a bit of an analysis of the Stigma Index reports that have currently occurred to date. So the Stigma Index is a tool, right? It's a research tool in which there are face-to-face interviews that happen between persons living with HIV about their experience of stigma. And so we know that stigma discrimination continues to be faced by people living with HIV in their faith communities. That people living with HIV believe that faith-based actors can help address the stigma discrimination they experience in their wider communities. And there is a way in which it's important to be addressing the internal stigma experienced by people living with HIV, that this is an area where faith communities and religious leaders can offer unique support and enable positive change. And that faith is of continuous importance in the lives of people living with HIV. Why religious leaders? Because religious leaders have extensive experience and knowledge in their communities. And they have reach throughout not only communities they serve, but in the wider community as well. And their faith gives them a sense of passion about caring for people who are in need. And they have some influence, some sphere of influence, at least over the community that they're serving. And many people place trust and confidence in their religious leaders. And they have some control over social capital, in which they can exert their influence in a community. Our aim through the Framework for Dialogue is to strengthen the responses from faith communities, religious leaders, and networks of people living with HIV to more effectively address the key concerns, experiences, and needs of people living with HIV. To strengthen partnerships to end stigma discrimination against people living with HIV and improve access to HIV-related services for all. And we want to base our actions for ending stigma on evidence drawn from the dialogue. The development and sustainability of long-term partnerships is also at the heart of this, encompassing both collaboration and dialogue among networks of people living with HIV, faith-based organizations, and religious leaders. So, and we want to collect and analyze and use evidence on the experience and perceptions of people living with HIV within their faith communities and responses to HIV of faith communities and religious leaders. The documentation and the sharing of good policy and practice, as well as lessons learned, help us to overcome challenges faced by people living with HIV and faith-based communities in the response to HIV. And the Framework for Dialogue is grounded in principles. I think you may be hearing that as I've shared some of these things already. It's country-owned. Originally, when the Framework for Dialogue was designed, it was designed as a country mechanism. In the US, we have to implement it on more of a local and regional basis. So in this case, in the US, we want it to be both locally and regionally owned as well. The dialogue is driven by that region and local partners and their priorities. And in the US, as I said, it's led and important that there's a good support and ownership by local and regional partners in the process. It's evidence-based. All the actions and dialogue are based on evidence, both quantitative and qualitative. So we take the learnings, the data from the Stigma Index report, and we lay that on the table as something that people can gather around and have a dialogue about. And our hope is that through that dialogue, people will come up together with joint actions that they're willing to engage in their communities. It's people-centered. The dialogue begins with the experience of people living with HIV and practicing their faith and the impact of the work of faith institutions on their lives, not vice versa. So oftentimes people may come to meetings and faith will talk about all the different things that they're doing. That's not the way the framework works. We begin with the story and experiences of people living with HIV, and then we ask, how can we work together to do better? And it's based on the universal value of doing no harm. That's an ethic that's universal, but it's also very much a part of faith values. All participants in the dialogue process agree to do no harm, to a do no harm approach, especially in the areas of disagreement. And there will be disagreement. It's inevitable. Stigma didn't arrive here overnight. It's not going to go away overnight. And people will have disagreeing areas of disagreement about what causes it and what people should do about it. And we have to expect that. But we also should expect that participants respect the confidentiality and identity of participants in the dialogue, and they agree to do no harm. That there's equal and meaningful participation. All stakeholders in the dialogue are equal partners, allowing full participation and involvement in the decision-making throughout the dialogue process and emerging joint actions. It's meaningful, not tokenistic participation from people living with HIV throughout. And it focuses on innovation. New partnerships are formed, and out-of-the-box thinking and solutions are encouraged. It's action-oriented. The focus of the process is to move beyond the dialogue to collaborative action and constructive actions. It's not just about the talking that we do, because we do an awful lot of talking. It's also about what we agree to do together, and not just what we agree to do together, but what we actually do, the actions that we take. And it's grounded in safe space. The methodology and facilitation of the dialogue aims to create a space where all entering into the dialogue can be sure that they will not meet discrimination or judgment. So what are the desired outcomes? Well, one is that we hope to strengthen and sustain collaborative and mutual understanding between religious leaders and people living with HIV. We hope to improve the quality of life for people living with HIV through faith-based responses that better address their experiences. We hope to strengthen the responses by networks of people living with HIV to the faith-related needs and their experiences of their constituencies. And we hope that we will have an increased engagement and visibility of religious leaders in HIV response in the epidemic, including HIV-related stigma reduction. We hope to improve the access to HIV-related services for people living with HIV and vulnerable to HIV. For example, sexual and reproductive health services and legal services. And we hope to strengthen and improve participation in and the quality of access to faith institutions and places of worship by people living with HIV, that they don't experience stigma when they go to their houses of worship. So the dialogue process has outputs. First we begin with the evidence, and then it places the evidence on the table for the dialogue. That moves to joint action, and then we begin again. Once the joint actions occur, we continue to meet. We have evidence about the joint actions and about the experiences that have happened there, and what is the impact of that. And then that in that dialogue leads to more ideas about the joint actions that we can take. It's an ongoing cycle. It's not a short term or one-off. It's an ongoing process. So we know that eliminating stigma is vital to ending the HIV epidemic, and the framework for dialogue seeks to make a difference by bringing together people living with HIV and religious leaders for an evidence-based dialogue about HIV-related stigma. And then the development of mutual commitments and joint actions to eliminate HIV-related stigma and discrimination and strengthen the faith response to HIV. We don't need walls between people, we need bridges, the former executive director of UNAIDS said, Michelle Sidibe. And I very much believe that's true. So my name is Reverend Michael Schuenemeyer. I'm the project manager for the Framework for Dialogue. And now I'd like to introduce to you Reverend Arthur Butler, who is our project coordinator. Arthur, there's Arthur. And Arthur, we are implementing the dialogue in these three communities, Detroit, Louisiana, and New Jersey. And I'd like you to share and introduce us to some of our colleagues who've been working with us there. Arthur Butler.
Great, thank you. And thank you all for being a part of this session today. And as Reverend Mike said, that I am Arthur Butler, Arthur Lee Butler. That's the southern part of me. I had the distinct honor of being chosen to be of service in the greater Detroit area, New Jersey, Baton Rouge, and New Orleans. And I'm going to invite some of the wonderful people on the team, my new family members in each of those, well, in two of those states, to come on and talk about the work that they did, the unique work that they did in the Detroit area and New Orleans. Mike laid out the objectives and the outcomes and the really the heart of what the framework for dialogue is all about. My role was really to bring about the personality and bring a more personal approach to that. I was an outsider coming into areas that the Stigma Index had been conducted probably some years before I was brought on. I came on in 2017. Stigma Index had been done in Detroit in 2014, and I believe 2016 in New Orleans and Baton Rouge. So my role really was to come in and introduce myself and to hear what those at the table had to say instead of bringing our perspective, really how we built those collaborations and these long-standing relationships that we have now that has been really dynamic. And the work that we are doing is has been really heartfelt and very meaningful in combating stigma in those areas. So I'd like to introduce and have them come on and they'll talk a little bit more about the work that they've done. Ari Hampton, who is out of the greater Detroit metro area. Ari was very helpful in me coming into the area and doing the outreach and bringing people to the table. Each of these family members will talk to you about their unique experience. So Ari, Chantel Maurice is in New Orleans, where we just finished our framework for dialogue. And because we are in the new normal, we had to go from an in-person framework session, a 2-day training, to a virtual training. And so we still tried to capture the nuances of being in person with each of the people who were on Zoom with us. So we have Chantel Maurice, and in Detroit, my dear brother and sister, Felix and Paula Ciros. Just lovely people. I can't say enough about the love and the support that I've gotten from each of the coordinators in those areas. And so I'm going to invite them to talk. Ari first, and then Felix, and then Chantel in New Orleans. So.
Well, hello, everybody. How are you guys doing today? Like Arthur said, my name is Ari Hampton. I'm from Detroit, Michigan. I was a part of the Stigma Index project at the first site here in the US in Detroit back in 2014. I was looking at the date like, whoa, it's been that long. So we started back in 2014 as a nice size group of people from the community, a lot of folks living with HIV, people that worked in the community, people that were just service providers. And we came together to kind of overlook this documentation of this survey that we wanted to do for the people living with HIV in the city of Detroit and across Michigan as well. I think we did a few counties, I want to say about 4 or 5 different counties. We had about 5 different people living with HIV, including myself. I myself have been living with HIV for the last 11 years of my life. And so each of the 5 interviewers were from different backgrounds that could identify certain populations that we could survey throughout the great state of Michigan. And so we surveyed about 70 participants. Participants range from like younger to older age groups. More were Black males, and in the city of Detroit. We had a lot of participants who were both from the LGBTQ communities and also the heterosexual population as well, incarcerated populations and also sex worker populations. Those were the specific communities that we wanted to make sure that those voices were heard. And so that experience was pretty unique. As a young person living with HIV, interviewing other young people living with HIV, specifically my trans sisters and sex workers, because a lot of those stories were my fellow brothers and sisters from the community that far too often didn't get heard. And so I wanted to make sure those were captured. Those experiences were healing, but also it was like walking through fire, because you had to relive those stories again. Hearing the stigma and discrimination that we all face, no matter what backgrounds that you came from. Okay, I saw a question pop up. I'll come back to that. But yeah, so, no matter what experiences we all came from, we had a commonality of wanting to be treated as human beings. And yet we still face the ugliness of stigma and discrimination in all facets of our lives, not just in society, but also in healthcare settings and faith-based settings. And this is what we wanted to capture, to make sure that not only we didn't want it to become a place where we were just pointing fingers at problems, but we wanted to identify what those problems were to create solutions and really understand how we could bridge those gaps and bring us together and not keep us separated as it has been for such a long time. So yeah, so a couple of those things. I think one of the stats that I love to kind of give as I comb through a lot of the statistical data that we captured here, but one of them in particular, especially for the faith-based communities, 88% of the population that we surveyed felt comfortable with disclosing to faith-based supportive systems about their HIV status. Out of that 88%, only 44% of them actually were given real support. And so those numbers are staggering in my eyes, especially as somebody that grew up in a Christian household and has a strong faith. This is kind of like what we turn to when we have nothing left around us, is our faith. And so this is why it's so important for us to have this discussion and to see where we could bridge these gaps, what we can do for each other, and how we can be there for each other.
Thank you, Ari. Go ahead, Felix.
Well, hi there. When the Stigma Index started, and when we started in the Detroit metropolitan area, I was working with the Detroit Health Department, as specifically in counseling and testing, and being positive over 30 years and working in different states, free states to be specific. I had experienced stigma on a continual basis in these states and in different aspects. But when the Stigma Index came in, we go in, my wife and I go into prisons, and we go in, and we also go into churches, and we talk to clinicians and deal with congregants who had family members who were positive. So we had an inroad in. My wife is a PK, a preacher's kid, and her brother is also a minister. So we had some inroads, and we knew a lot of pastors because we were called in to talk to families and to educate pastors that had either been didn't have the information to really serve the population of HIV clients and individuals. So also doing workshops and on a weekly basis with people who were positive. It gave us an insight into the population, and also we were able to talk to most of the folks who went to churches. We could talk to them and then present to officers of the church not disclosing their status, but really talking to them about what they needed to know in regarding to helping their populations and their parishioners. It was wonderful project. In the prisons, that is a huge area and still continues to be a huge area because it involves politics and so forth. And being able to go into those prisons and talk to inmates was really an important issue. Also, newly released inmates coming out of prison, that's a huge area. So we had 5 basic areas that we really saw that needed to be addressed. One was the spiritual community. One was returning citizens. Ari, can you help me out a little bit? I think one was
I think it was men who have sex with
men who have sex with men, and I think that we also had the transgender population, if I'm not mistaken.
Yes, it was the social engagement and support of faith-based communities. It was HIV criminalization, youth justice, and also the trans justice as well.
Right. And so working together with the outcomes from the interviews, we were able to really center in on some areas that needed to be addressed and form presentations to present to churches and to communities that where we could educate. And, you know, when you go into someone's house, if you need to take off your shoes, you take them off. If you go into someone's house, you don't go in with blame, you go in to create an atmosphere of trust. And those were the areas that we really wanted to address and do, was not to point fingers, but to solve problems. You know, if we had to go in and do a poem or saying, we did that. Sometimes we were only given 3 minutes to speak, and sometimes we were given at the whole hour where the minister would give up his time. So we took what we could get. And in doing so, a trust was formed by the pastors, by the community, by the parishioners, where they could call and speak with us about issues. And so referrals were created, and also bonds that still exist to this day.
So with that said, you guys, y'all notice we are not home. We are grandchild sitting for, which I love, because we, you know, it's a pandemic and we still can do just limited things, but I'm grateful for that. But as Felix stated, you know, as a PK, a preacher's kid, it allowed us an opportunity to speak to a lot of ministers that we knew personally. Now, it's never always easy. We have gotten doors slammed in our face. Some people, as Felix said, I remember distinctly the 1 minute we had to speak, we had sat in this cold church at least 3 hours. And I'm not joking, you could see your breath. And when we got to the podium, before I could say one word, the minister looked at me and said, you got 1 minute. And we were the first ones on the scene. I just started singing the Lord's Prayer, a cappella. That gave me 5 extra minutes. So I was grateful for the 5 extra minutes. But as a result of that, one of the things I really want to see us do and go forward with is our communications with our religious community. The doors are open. A lot of them were shut, but a great many of them are opening. I try to keep my feet in the ones that are open and create, you know, continue that collaboration. Unfortunately, with the pandemic, we can't physically be there, but Zoom allows us to be right there with the doors open once again. And we have been collaborating with a bunch of ministers. And I'm gonna say this, and I'm gonna close on this point. How we have been able to get into a lot of the churches here now is due to COVID. And they have really wanted to talk about the spread of COVID. Now, the intricate part is COVID and HIV, they are so similar. There's a lot of similarities because they also face stigma and discrimination. And fear. So we were able to talk about the both. And then a lot of the ministers, a few of the ministers that I know, their whole family was affected. The minister, his wife, they lost a mother-in-law. And this is one family. But he also was one of the first ministers to allow us to come in his pulpit and talk about HIV. So with that being said, he really told us how he can actually feel how we felt when we walked into that church and started talking about HIV. He felt that discrimination because he also had COVID, not HIV, but some of the stigma was almost parallel.
Yeah. Thank
So
you.
that has and is giving us an opportunity to bring it right back on the forefront, and let's talk about it. The difference is, one of the pastors pointed out, is that COVID, you can die. I can cough on you, you'll be dead tomorrow.
Thanks.
HIV is not that difficult yet. From 1980 to today, the stigma is still so thick, and it has never changed.
And when we look at the change in policies, laws around HIV, which are starting to change, we've had to go before city councils and present papers to the Senate. All of these things are important when we look at stigma and how we change stigma, because some stigma was based on law and lack of knowledge.
And now we have the knowledge. Hosea 5 and 6. We perish for lack of knowledge. And if we don't spread it to our parishioners, that's one of my quotes I use when I walk into a church. Amen. They can't deny that, so they have to hear what we have to say. Thank you guys for letting us present.
Thank you. That's the benefit of being a PK.
Yes.
So with that, I want to introduce my sister in New Orleans, who has just been a dynamic part of the family. And through storms, we were faced with many challenges. And one of the many challenges was that every time that we were scheduled to do a framework for dialogue, New Orleans and the Baton Rouge area was constantly under threat of hurricane. So with that, I give you my beautiful sister, Miss Chantel Maurice.
Thank you. Thank you so much. I just want to say, it's a pleasure to be on this panel with everybody. I feel honored and just so grateful to be a part of, such an amazing network. My role here in New Orleans was to support and to develop long-term partnerships among networks of people living with HIV, faith-based organizations, and religious leaders. We worked every avenue of outreach by reaching out to faith leaders on Facebook, Messenger, phone calls, in-person calls, letters, writing any necessary way to get them to come to the table. It was challenging, but we made it. We made it. I mean, because of COVID, it created challenges, but just as Paula stated, that it opened up doors too. And the utilization of Facebook, because churches were streaming live, right, actually made it a little easier to connect. So yeah. Our Zoom experience during our virtual trainings were very good. We were able to really come together. We were able to really share. We were able to, identify strategies, and now we're just excited about how we can implement those strategies, right?
Yeah.
That's all I have.
And the New Orleans and Baton Rouge group, they were funded through the Compass Initiative. And that's one of the things that we work also towards, is in building those sustainable collaborations, is to hopefully work with those partners in those states to identify additional funding that can support the efforts and the work that they're doing. We were able to strategize with the groups into the first quarter of 2021 in hopes that there are other funding streams that are coming out, and that those strategies and the evidence and the practices that came out and came through during those trainings could show up in those requests for funding application. And I'm going to turn it back over to Reverend Mike. And thank you again. Thank you to Paula and Felix and Ari and Chantel as well.
Thank you.
Thank you, Arthur, and thank you for everyone for your wonderful sharing of your stories and things. And I think the thing that I wanted to ask as we get into our question and answer time, and I see that there's some questions in the Q&A, and we're going to get to those right away. But I'd like to do a little bit of a conversation about what do we feel some of the important next steps are. I mean, here we are in the middle of COVID, and we're likely to be here for another few more months. And so we've heard a little bit about some of the engagement that has occurred. Well, what are some of those next steps? What do we hope that the framework might be able to do in your communities?
I know I had a few things that I always kind of jot down, which are always kind of like been my hope since day one. You know, education is always important. Especially during this time of COVID going on right now. I think this is a pivotal time where health education is so important that we need to start providing those trainings inside of our faith-based environments. You know, even if that's just for the pastor and the bishops themselves, or whoever that may be who's leading the worship, so that when your people are coming to you asking for answers because you guys are the pillars of the community, they're going to turn to you for information. And so you need to make sure that not only the information that you have is factual, but you also have the reliable resources that you can provide if you don't have those answers. That's something that should just be mandatory across it's so simplistic and easy. Even if it's just conversations reaching out to folks who work at CBOs or aid service organizations and just saying, hey, I just want to get educated. It costs you nothing to learn, you know? And so that's one of the areas. I think another thing, speaking around the terms of being pillars in the community, is becoming advocates for people living with HIV. Faith-based leaders, you have some powerful ways of influencing people who are not just in certain communities that are like healthcare workers or anything of that nature, but you also have influence over people who are actually creating laws. And so putting your faith into the way that you work with your communities and advocate for better laws that support the sustainability of life itself is so powerful. So that's something that I think I will leave in your ear a little bit.
Mm-hmm. Before others respond, Ari, there was a question folks had for you around the organization that you work with, and I wonder if you would share that with us. You're on mute. Uh-oh, we lost him. Well,
This is. Can you hear me
there
now?
he is.
Yes.
Okay. I'm so sorry. I'm like, what happened? Okay. You say that one more time, Mike? I'm sorry.
So someone asked about the organization that you work with.
Oh, so I'm with the Detroit Std Clinic now. I just started here maybe about a year and a half ago. Before then, I worked with Horizons Project, which is one of the first leading clinics for young people living with HIV since 1994 here in southeastern Michigan. So I've worked with young people living with HIV from the ages of 13 up to 29. I know young people, you say 29, but yeah.
Right. Right.
And now I work with everybody, doesn't matter your age, background, whatever, I'm here for you, man.
Great. And could you nutshell what HIV looks like in Michigan?
So HIV right now, the rates are still rising, you know, due to lack of education, due to fear and stigma that's still, you know, still the ugly monster here. A lot of people are afraid to step up and come get tested, especially, and not just in the MSM population. We say MSM for a lot of people who don't work in public health. MSM is just a standard term for healthcare workers that say males who have sex with males. Never call somebody that out in the real world. But Yeah, so the rates right now are pretty high for males who have sex with males, especially males of color in that demographic, and also Black women as well. And so making sure that the heterosexual population is receiving these messages is extremely important. Not only those two communities, but also trans people of color are specifically affected at higher rates than what we're seeing, because a lot of their information and demographics are not being captured correctly. And so these are things that we need to make sure that as faith leaders, as people of faith, I rather say, as people of faith, we need to think outside of ourselves and really understand that our heart can go a long way in saving each other and saving a life.
Thank you, Ari. Thank you.
Can I reiterate on that just slightly?
Sure.
We had a centralized system, Detroit Health Department, that was centralized in one location that addressed many needs of the community. It was a one-stop shop. Also, when we had educational programs, when the rates started to drop on in our community on HIV, those funds were depleted and stopped, which created a lack of continual education in our communities, which also led to the rates starting to rise again when there was not the participation from a state level to keep educating our communities. The programs in the schools, which we had started, also decreased. So there was a lack of education in the community across the board. So the rates have increased, and now with COVID and the lack of people being able to get out, there's not enough outreach in the community. There are many community-based organizations that do call and are trying to really bring it, but we need the spiritual community also to get out, visit, to make calls and help folks because of the mental issues of being alone and depression and substance abuse, which COVID has created.
And just to kind of add on to that aspect as well, when Felix is talking about the prevention and outreach of folks, it's not just people who are negative or at risk, it's also for people who are living with HIV. A lot of our support systems for people who live with HIV have been taken away. Not too many support groups that are out here. And these are supportive groups that are really pivotal in people living with HIV, because we're talking about disclosure, we're talking about medication adherence, what undetectable means. And now that we know that undetectable equals untransmittable, what does that really mean for folks? And these are terms that we really, really need to have conversations around. I know it's a lot of information, it's a lot of education, but just providing those safe spaces that are confidential can go an extra mile to just allow that education to be put out there even more.
Chantel, I wonder about the experiences that you've had or what you've noticed in New Orleans, particularly around the relationship between stigma and mental health.
Ooh, stigma and mental health, well, has been an issue here in New Orleans, Louisiana, and I'm sure everywhere, right? I would have to agree with Ari and what he said about having more education, and more support. And that's definitely needed for mental health as well as stigma of people living with HIV. Well, what we see is that there's more support groups for people with mental health conditions opposed to people with people who are living with HIV, right? So I would like to see that more here in New Orleans, and we don't. I do think that re-education, and I say re-education is because I think that we've all been educated, but oftentimes, it's a lot of myths, right? On how you can contract HIV or, just about health and wellness and taking care of yourself. And I just think that in the African-American community and community of color, we stand on those myths, right? And so I think that's very important that we go out and we re-educate. Community outreach is very so much needed and important. So,
And we just finished in New Orleans, and we had an opportunity to talk to the faith leaders who were at the table, and we asked them what can their faith-based organization do to reduce stigma, and it was interesting to find out. I say interesting more than surprising, because what we heard, and Chantel can remember, is that there were activities going on in the in that area that some of the churches used to participate in, had stopped participating in, didn't know that they were still going on, you know, were if it was an excuse, we don't know, but they were encouraging people to come back and bring them the information, because those relationships had been built. But we had Chantel pulled together a group of activities that happens between November and the first quarter of the year, and so that we could give faith leaders there an idea of how they could participate without funds, but how they could participate in things that were already existing, whether it was World AIDS Day or Church Week of Prayer, just how they could think about, before we come back together in December, some ideas of what they can do within their own organizations with the things that they're currently doing, whether it's through a health ministries or a nursing ministry or a care ministry, that they could partner with Chantel and her group and come on board and be advisors. And what we found is that we had people step up to the plate. We had a bishop and two other pastors in the area who were very interested in being a mouthpiece for bringing other members of faith to the table.
Yeah.
So we have about 12 minutes left for our session, and I want to get to the questions that we have in the Q&A. So I'm just going to go there and then invite our panelists to respond to things that stick out for you. So the first is a question by David Barstow. Principle 8 describes safe spaces for all participants. So what would be the guidance to ensure that the dialogue space is genuinely safe for everyone? He says he's been involved in discussions where it seemed much safer for people living with HIV than for religious leaders from conservative backgrounds. So that's, how would you respond to?
They can hold some of those meetings in the church.
Well, I would say that number one, it has to be a place that is away from the normal, like it should not be in a clinic or a hospital setting, or even a community-based organization. Sometimes we found that it needs to be in a, we've done them in colleges, college buildings, which has really been nice. A lot of the colleges are really open and have spaces for the community. And so we use those spaces. Churches and CBOs are not always the best places because there's a stigma sometimes associated with them. And so if you have a free space where everyone can feel comfortable and that there is no stigma put on those locations, I think is important.
Good question.
One of the ways in which I would also respond is to recognize that the framework for dialogue is a process. And so one of the very first parts of the process is actually preparing for the dialogue. And it calls for there to be a core group first that's composed of faith leaders and people living with HIV. And the task of people who are facilitating the process is to help that very core group create that safe space for each other from the outset. And sometimes you have to start meeting with them separately before you bring them together so that you can prepare them for the relationship with each other and prepare the groundwork, help them to get grounded in the values of respect and the values of listening and the values of empathetic listening. And that's something that has to happen on both sides, because as we've had negative experiences from both sides of the dialogue, we will ascribe to each other a harmful intent. We don't mean to do that necessarily, but we want to protect ourselves, and so we will withhold, or we won't be forthcoming, or we'll do things that will inhibit the ability to actually create the space. And then somebody says something that triggers, and then you have a conflict. So you have to create the space with each other, build the relationship of trust with each other, so that you can get to that place where the space really is held for each other. Even, and you really do want the diversity of voices in the room. But you have to be careful. You can't have the most extreme voices in the room, because it's not helpful. It can be harmful, and you have to really work hard at that. But creating the space where people can authentically be themselves and share their stories is a place where people can find empathy with each other. And that will do more to change hearts and minds and bring people together where they can actually work together than anything else, I think.
I think that's also to Felix's point earlier was about knowing your audience and knowing where you're going and how to present yourself. And I think one of the benefits of doing this work virtually now is that it neutralizes the situation. And so we're in cyber world, and we're in the new normal as it is now. And so it's not attached to an organization or a church. It's all of us coming together and looking at those unique ways and how we talk to one another and treating each other with that mutual respect and bringing that respect and making sure that everybody is heard, and that that the facilitator that's moving that conversation is key and in that situation, because he or she then picks the themes out and allow people to share freely about those without anybody feeling or coming under attack, because we're not there to point fingers. We're there to build upon the things that we have in common and the things and the common goals that we can at least have conversations about.
I want to say this one little piece. I remember in our past, when myself included, I remember speaking back in the day about being church hurt.
Mm-hmm.
And I would come in with an agenda because I wanted to let them know how they made me feel. What I recognized in that was the church that I was presenting in, those folks didn't know me from Adam. They were not the people that hurt me. And I had to really realize that. So when we had gotten our group of speakers together and we trained them to go out to different venues, we talked about some of the things that we did in our past to correct it in our present. So when we do speak, we don't speak that same little hurt and that anger that we had before. You are in a whole totally different church. These folks, you know, you in the door, so the door is open. So we try to, right. So and don't close it. So we try to educate our speakers as well, so they can not only speak from a place of personal, but speak for everybody in general.
And we have had the opportunity to have workshops with people that were in pain and that were injured, and to work through some of those issues and to discuss them so that some of that anger would start to ebb, and that you know, sometimes you to create change, you know, you have to give, and you have to also forgive. And don't expect people to forgive you, but we have to forgive because of other people's transgressions. And to really create that dialogue is extremely important. And thank you, Reverend Mike, for bringing that up. It's huge.
Yep. I know that we're beginning to come to the end of our time, and I'm worried I think we may not get to all the questions that have been asked, but I know there's a question about meaningful engagement with adolescents and youth, and my thought about that is that how important it is to ground what you're doing in values and to implement those values as consistently as you can. And I think values that we undergird, for example, our comprehensive sexuality education work in are the values that are related to self-worth, the values of responsibility, the values of health, not just my health, but another person's health as well, and the values of justice and inclusion. And when we think about those values and we think about the curriculum that we offer, there's not a question we can't answer that we can't use the lens of those values as a way to engage. And when people know that you're serious and you engage with the values that you hold dear with integrity, I think it says something and enables people to engage at a level that's meaningful and creates a sense of healing and wholeness. That's the kind of thing that I would certainly think could be a strategy and approach to doing that, because then it doesn't really matter what you do, as long as it's grounded in those values, it will be true.
Yes.
The other question is around the source of shame and stigma, and that I think that's a response that probably requires volumes. But I think that what we've heard today, in many ways, is that a source of stigma is culture, because we learn to treat people differently through the way in which we experience culture. We grow up. It's not always intended, but the way in which we view our world and others is often something that's very deeply cultural. And religion itself has its culture. I think the framework for dialogue asks people to think a little bit differently about its culture without abandoning their values, and to use the values that we can share, the values of do no harm, the values of universal love, right? The love of neighbor, the love of self, the golden rule, and that those are the values that provide a space where we can gather around and engage around evidence that can lead to joint actions to actually not cause harm. It's not easy work, and we don't get there overnight, but I do think it's something that we can work at and be persistent about along the way. I want to thank everyone who's been part of our conversation today, Ari, Chantel, Felix, and so happy that you're with us, Felix and Paula and Arthur. Thank you for joining us. I want to thank Ulysses, who's been behind the scenes helping to manage the chat and the Q&A. We're so grateful as well. There's much to look forward to. We're grateful for the opportunities that we have to engage, particularly as we engage with the framework, with the framework for dialogue, but also with the conference going forward. And I want to remind folks that there's more that's happening in the International Stigma Conference the rest of this week. And so if you're not registered or haven't yet, or you want to select sessions, you'll find them at whocanyoutell.org or at your Whova app. And also the U.S. HIV and AIDS Faith Coalition is hosting an interfaith service on Tuesday, December the 1st. It will be live streamed on facebook.com/USCA Faith, and also on YouTube at our YouTube channel. And you'll find out times. We haven't announced all the times yet because we're still working that out, but you'll find them at uscafaith.org. So thank you everyone for being a part of today's session and for joining us. We're so grateful that you are here. We wish you well as you move forward, and we look forward to partnering with you in our work to reduce and eliminate stigma. Goodbye, everybody. Take good care. God bless.
Thank you.